And that, ladies and gentlemen, just makes them think you're a star. You got this. Okay, okay, so do that. Hey guys, welcome back to my channel. My name is Aoyetoran. I am a fourth year medical student. If this is your first time here, please go ahead and hit that subscribe button, okay? Today, I'm going to be talking to you guys about my internal medicine rotation. Now, if you've watched some of my videos, you know that normally I talk about my rotation from my experience and then I give shelf exam tips towards the end. But because this is internal medicine, and for a lot of people, internal medicine is a huge exam, I'm going to be doing a separate video on tips to succeed during your internal medicine clerkship. So this one is just my experience. I started internal medicine in February 2020, and come March 2020, we all know what happened to the world. The world experienced this pandemic as we know it now. So unfortunately, my internal medicine rotation was cut short, and it ended up looking a lot different than what most people's internal medicine rotation looks like. For me, I was able to do 4 weeks in person, 4 weeks. Then, Corona slaps us across the face. We all thought we were going to go home for 2 weeks, right? And then that became several months. Eventually, we were able to set up an online system where we were learning. We would go through patient cases together, different clinical scenarios. Students would present different topics and whatnot. That lasted for 6 weeks. So now that's 10 weeks. My final 2 weeks happened this February that just passed. So it took me a full year to complete my internal medicine rotation. What? So I'm going to talk about the 4 weeks on the floor and the 2 weeks, the 4 weeks on the floor and then the separate 2 weeks that I did later on. And I'm going to talk to you guys about my experience from that point of view. Most people are back to the hospital. If you're not back to the hospital and you want me to talk about my online experience with internal medicine, please let me know in the comments below. I definitely will do that. The 4 weeks of internal medicine, I got to rotate through a team, and a team being a team on the floors. So these people are responsible for the patients in the hospital. And I got to rotate through the CCU, which is the coronary care unit, or just the cardio version of an ICU. Patients in an ICU usually require respiratory support or just constant monitoring, and patients in the CCU usually have some sort of cardio problem. So this could mean they just had a CABG surgery, which is a huge surgery that happens when you have a heart attack, a massive heart attack. There are criteria that have to be met for you to qualify for a CABG, but you go to the CCU right after surgery, or you have some sort of arrhythmia. I don't know why I keep mentioning arrhythmias in my videos. Take a shot every time I say arrhythmias. Take a shot of water, because we are all about health on here. And the last 2 weeks that I did last month, I rotated on the floor as well. So things have changed between last year and this year in terms of the rotations. Firstly, one thing is we did not have COVID-19 patients last year, but this year we do. So you see, like most schools, my school, St. George's University, makes us do a 12 weeks long internal medicine rotation. That's 3 months of your life, ladies and gentlemen. Fortunately for me, I like internal medicine and I was interested in internal medicine, so I didn't think it was that long. As every other rotation, 12 weeks are divided into different subspecialties, different teams. So as a student on the floors, what are your responsibilities? A student's responsibility would be to come early on time. Some students come 30 minutes early, although for my rotation, no one was really doing that and they did not expect you to do that. It wasn't a rotation that favored gunners more than everyone else. But if you are in a situation like that and you do want internal medicine, please go ahead, by all means, get there at 6 a.m. okay? For us, we had to get there at 6:30. The residents would sit down and have the list printed out. Then the night float would sign out to the residents, but because the residents didn't want us to be influenced by whatever it is that the night float just told them about the new admissions, they assign us patients right from the get-go. So at 6:30, you're getting 2 patients for the day, and you skidaloo, you go your separate ways and you go see your patients. Usually they're new admissions, so this means that the attending does not know about them usually, and you have to get their full history. So from beginning to the end, I'm talking about, you're taking HPI, your OPQQRSTs, or I know people who do, is it old carts? There's old carts for the mnemonic. You're doing your full past medical history, medications, allergies, social history. You're taking surgical history. Have they been hospitalized before? Depending on what the situation is, you might have to take an OBGYN history as well. You're going to do a full ROS. You're doing a full physical examination from head to toe. We don't do focused in internal medicine, okay? Especially when the patient is new. So basically like an OSCE, except the part where you don't tell them their diagnosis because you probably will be wrong. So once you do that for your 2 patients. Last year, when I did my rotation, students did not have to write notes at my hospital, but depending on your hospital, that might change. That changed for me this year when I completed my last 2 weeks. I was writing notes as well. So it just depends on your hospital. Make sure you find out from your resident. You should also ask, because that shows them again that you're interested. So if you want to go ahead and ask your resident, would we be required to write notes? And if they say no, then you can say, okay, but I would love to learn how to write notes. And that, ladies and gentlemen, just makes them think you're a star. You got this. Okay, so do that. I'm giving you all tips for free. So that's what is expected of you. When you are done doing that, so then you go sit down at a computer and you go through your patient's laboratory results. Usually every patient that comes into the ER and gets admitted does blood work. They do blood work on almost everybody. So you go look through their labs, see what is abnormal. Is their potassium low or high? There's the fishbone that every internal medicine student, every internal medicine resident lives and dies by. You want to know their WBC counts, their hematocrits, their hemoglobin, their platelet count. I'm going to put a picture of the fishbone. The fishbone it literally looks like a fishbone. And if you see that anywhere in medicine, the certain slots represent certain things. I'm going to draw it with my hands, okay? Bear with me. So this is a fishbone, okay? This part represents sodium. This is potassium. This right here is chloride. This is CO2 or bicarb. And this part here is BUN. Right here is creatinine. And then the tail of the fish tail, the tail right here has the glucose of the patient in it. Make sure you have that written down for your patient. Then there's the crisscross, where this part over here is the WBCs, literally right opposite it. So over here is your platelets. Here is your hemoglobin and here is your hematocrit. So write out labs, check if there are any radiology things that they did. So did they take an x-ray for this patient? Patient came in with shortness of breath, chest pain. Chances are they took an x-ray, they did an ECG. So yes, check that. Check to make sure that you know what was read on the x-ray. You know what the ECG says. If they did a CT, for example, of whatever part of their body, you want to know what the result is. After doing that, then you come up with your diagnosis for the patient. Usually, if there's an admitting note, you should read the resident's notes, by the way, if there's already an admission note in there. Usually at the end of the admission note, the resident has the diagnosis written out, and they have other differentials as well. But one thing that would impress an attending is if you think it's something else and you can defend it, that's something you can include in there as well. Or just knowing what the diagnosis is based on what the resident has said, or if you came up with it yourself, and then being able to explain to the attending what the diagnostic criteria are. So for example, for endocarditis, which is basically the inflammation of the valves in your heart, you want to know what Duke's criteria is. You want to make sure you try to read up on it. So usually after you've done all this, your resident is probably on their own doing their rounds as well. Depending on who your resident is and how comfortable you are, they might have you present to them first. So you might present to your resident first, and then your resident will correct you, tell you what you need to add or you need to take away. Then you get to present to your attendant. At least that was the way it was for my rotation. Different attendants have different styles. Most people in internal medicine want to hear the past medical history. Some people don't. So, ask your resident so you don't end up giving this man a full story that he's just going to be looking at you like, okay. But most times they want the full story. In internal medicine, we like stories. In internal medicine, I want to know who your grandmama was, how she died, if she died, did she have cancer, did she have heart disease, all of these things. I want to know what you ate for breakfast, because if your pain started after eating breakfast, what did you eat? Did you drink this morning? Perhaps. Like internal medicine, we want to know everything, because every single part of a person's life affects sometimes how their disease progression goes. Did that make sense? I'm gonna say it again for those of you at the back. Every single part of a patient's life could affect negatively or positively how their disease progresses. So that's all important. For example, smoking. Somebody who smokes, you expect, firstly, they're at high risk for a lot of things. Abdominal aortic aneurysms, that's actually hypertension. Smoking is high risk for hypertension, which is high risk for aortic abdominal aneurysm or abdominal aortic aneurysm. Smoking is high risk for coronary artery disease. So that is basically what is expected of you. Learn their story, know your patient back and forth. If your attendant says, oh, but what was their calcium level, you want to pull it out and be like, baby, I got it. Know your patient like the back of your hands and be able to reason with them as well. When your attendant and resident are talking about, oh, it could be this, it could be that. Girl, boy, throw something in there that you think it might be. One thing I've learned is that it's better to give a wrong answer than to be quiet sometimes, especially when it comes to medical situations, because if you're quiet, they just won't notice you. But if you're bold enough to say, I think it's this, and it makes sense. Now, don't look at somebody who's short of breath and has chest pain and be like, oh, they probably have a migraine. Make sure there's reasoning to the answer that you've given, and they'll say, I get where you're coming from, but it's not that, and then there's respect there. Now, the next time they might be like, oh, what do you think? And again, remember, we have to get those letters. So that is always good. Being in the CCU for me was also an experience, although we didn't get to do as much in the CCU. But one thing I did learn how to do in the CCU/ICU, because some of the patients are also in the ICU, was to take an ABG. An ABG in the ICU/CCU is bread and butter for a lot of things. A lot of patients in the ICU/CCU are on vents. So that means that a machine is breathing for them. So one way that we find out if they're adequately being oxygenated and ventilated is by doing an ABG. So if you find yourself in the ICU or CCU, please ask your resident if you can practice doing an ABG. It's different from just getting blood from a vein, because with an ABG, arterial blood gas, you're going to the artery. That's a very important skill to learn. Also, putting in central lines. Obviously, we're not allowed to as medical students. Well, we're allowed to put in IVs. We actually do learn that during basic sciences, but you're not allowed to put in central lines, but you can watch. So make sure you take advantage of that if internal medicine is something that interests you. So that was last year. This year for me, when I rotated for my last couple of weeks of internal medicine, I was considered a 4th year student. And that's because I had basically finished all my core rotations and I just had this 2 weeks of internal medicine left. And I was fortunate enough to work with the resident that I worked with last year. So he knew me and he trusted me enough. So I did a lot more. I basically was a 4th year student. I had more patients on my list and I got to do follow-ups more than I got to do in my 3rd year. So follow-ups means that I saw a patient maybe at the beginning, did the full HNP, and then I got to follow up with them. So it's like, oh, this patient came in with a pneumothorax. We put in a chest tube, x-ray showed this. Let's say they developed some sort of a pleural effusion. Whatever happens the next day, if we needed to get a CTA, if we needed to do an x-ray again to make sure that the pneumothorax is being resolved, then that is something that, I would present to the attendant the next day. Oh, this is where the new findings, this is where the patient is at. I liked that a bit more because that felt more like residency to me and what I would end up doing. I think internal medicine is a great place to learn a lot of things because we see a variety of patients. Same with family medicine as well. Everybody who comes into the hospital is assigned an internist. First of all, an internist basically coordinates with everybody. If a patient comes in and we need an ID consult, maybe they don't have good renal function, so we have a nephrology consult. At the end of the day, these people make decisions and then the internist decides how to proceed. Another thing I love about internal medicine as a whole is that you never stop learning. And honestly, there'll probably never be a boring day at work because everything is different. People can have the same illness and present in several different ways, and it's just interesting for me. Internal medicine to me is almost like a puzzle. It's like having different little pieces and having to put together a puzzle. Internal medicine, I'm sure you can tell, was fun for me. I believe I do want to do internal medicine and then specialize in God knows what. I don't know what it is that I want to particularly specialize in. I do have interests, but that's a story for another day. If this video was helpful to you, if it broke down things, please let me know down below in the comments. Also, give this video a thumbs up if you enjoyed it, and don't forget to subscribe if you have not subscribed. Thank you for watching. All right, bye now.